Okay, thank you everybody for coming to Symposium 14, Alphabet Soup, PFT-GLI-MBW-LCI, and you all know what that means, which is why you're here. Or if you don't, you are about to find out. I'm here with my co-moderator, Kenny Harker. Kenny is a respiratory care supervisor of Pulmonary Function Lab at Corewell Health, where he oversees PFT testing at 7 outpatient pulmonary clinics and the Heart and Lung Transplant Center. Kenny has been involved with the Adult Cystic Fibrosis Care Center at Corewell Health for 9 years. He's also highly active with the AARC and has been the Diagnostic Section Chair since 2023.
And Matt is the Assistant Director of Respiratory Therapy at UCLA Santa Monica, where he oversees inpatient operations, U-Breathe readmissions and education program, and ambulatory respiratory care services. He is active in quality and research, securing multiple research and quality grants, and regularly presenting at national and international conferences. He has been involved with the North American Cystic Fibrosis Conference for over 11 years. And Matthew also chairs the UC RT Collaborative and the CSRC Managers Association for Respiratory Services.
Okay, thank you everybody for coming today. We have some really great presenters from around the country. Our first speaker is Michelle Marshall. Michelle is from Johns Hopkins All Children's Hospital in St. Petersburg, Florida. She is a registered respiratory therapist with 20 years of experience and is a certified pulmonary function technologist. She has her bachelor's degree from Liberty University in psychology, and her degree in respiratory therapy is from Santa Fe College in Gainesville. Michelle has specialized in CF for the last year and a half, and this is her second NACFC. Welcome, Michelle.
Hello, everybody. All right. Thank you very much. Again, my name is Michelle. I'm from Johns Hopkins All Children's in St. Petersburg, Florida. And as Matt said, I'll be talking about the forced oscillometry testing. Some might think that is a new diagnostic for a new concept. So let's look at the history. In 1956, Arthur Dubois described the forced oscillation technique as a tool to measure lung function using a single frequency sound waves generated by a loudspeaker and passed into the lungs during tidal breathing. He was the first to measure pulmonary resistance with forced oscillation and lung volumes in the body box. A modification of this original idea is what we also refer to as impulse oscillometry, or what you might know as IOS today. So how does it work? An impulse generator produces small amplitude external pressure oscillations at a given frequency delivered into the respiratory tract to detect and localize obstruction into the respiratory system. A little about the details of the FOT. The forced oscillometry it's non-invasive. It does not require anything except for just breathing at regular tidal volume. Disturbances in flow and pressure from the impulse generator are caused by the external sound waves passing through large and small airways and are used to calculate mechanical properties of the lung. So oscillation defined is basically the movement back and forth at a regular speed, like an oscillation fan. A little about sound waves. Sound is a type of energy made by vibrations. The number of vibrations per second is called a frequency. Frequency is measured in hertz. So 1 vibration is 1 hertz. So 5 vibrations would be 5 hertz. 20 vibrations would be 20 hertz. What most would think would be a fast vibration. If you look at the screen, the 20 hertz is actually the very fast waveform you see there, and the 5 hertz is actually the very slow vibration. Most would think the 20 hertz would go a lot further because it's a higher number, but it's actually the opposite. So the 20 hertz is actually a shorter distance because they're in such a hurry to get where they need to go, they actually die off faster. So when the 20 hertz is put in, it doesn't get very far because of dying off faster, so it only gets to the larger airways. The smaller hertz, which is the 5 hertz, it can go further, kind of like slow and steady wins the race, so it has the ability to go to the smaller airways. So looking at this picture, you'll see in the top left corner, you'll see block A. That is a picture of, it's a drawing of the loudspeaker. You'll see the blue waves. The blue waves represent the disturbances in the flow and pressure. That's what's happening there. And then it goes into the airways, entering the lungs. The green waves are representing the resistance. So the lung is starting to feel the resistance coming from the flow and the pressure. And entering the little red waves you see there, welcome to the alveoli. And that is where the lungs are starting to react. At the bottom in the square where it says C, that is what a child would look like experiencing the test. The box that you see, that would be what a generator looks like, that will be generating the sound waves. I tell our kids that's like the brain. That's what is creating the sound waves. They can't really see the screen, but from the therapist's point of view, you'll be looking at the sound waves on what you can see on the screen. And if you notice on the picture, the child's head is got a slightly upward tilt, and that opens up the airways so that they don't really have a choice on which direction their head is facing. That way it allows the airways to be automatically open. Use a basic filter, just like you do with spirometry, and a nose clip on the nose. So just like with regular PFTs, you're only breathing in and out of the mouth. The hands on the cheeks are to avoid any kind of movement with the cheeks. And I'll show you more on that later. So during this, what is being measured? So the 3 things being measured are resistance, reactance, and impedance. So resistance you can think of as R, reactance is X, and impedance is Z. The resistance is basically any narrowing or constriction of the airways, just the openness of the airways, represented in the oropharynx, larynx, trachea, large, small airways, lung, chest wall. Just think of resistance as R. Reactance is the expandability, elasticity, anything in the lung tissues and chest wall. And the impedance is Z, and that is the sum of all forces, anything working against the oscillatory airflow that we are putting inside the respiratory system. Z, if you think of it easier, Z is at the end of the alphabet, it's also at the end of the equation. So R plus X is going to equal Z, so we're adding the resistance plus the reactance to give us the impedance is what the measurement is asking for. We can basically send sound waves down into the airways, see what comes back to us, and we can localize where the obstruction is coming from, the large airway, the central airway, or the peripheral airway. This is showing us the frequency. So going back a couple of slides, we talked about the frequency. The larger frequency doesn't go as far as it will get just far enough get into the large airway and it dies out quickly. But the smaller frequency can go a lot further because slow and steady wins the race. So looking here, the larger frequency of a 20 frequency, that's going to be super fast. You'll see on here, the large airway can only go up to the 20 frequency, and then it dies out, and you will not be able to get a reading or a measurement from the small airways down to the alveoli. And then on the blue arrow, you'll see a frequency of 5 that can read the entire airway. But if you notice, there's not a way on here representing by arrows where you can only read the small airways. So how do we get the measurement of just the small airways if you only have a 20 and a 5? Just like how we do PFTs where you have to take one and subtract the other to get the answer that you're seeking, you can take the R5, subtract the R20, and that will give you the answer that you're looking for as only the small airways. So the R20, the 20 is the frequency, That will give you the large airway. The R5 will give you a total airway, and in order to get to only the small airway, you would have to subtract one from the other. So that will be the difference. So this one's got a lot on it. The interpretation and application. This will summarize the peripheral, the central, and restrictive airway disease. And then we will go over what some of the tests actually look like. So again, remember the R is resistance, X is reactance, and the Z is impedance. Z is not going to be mentioned here because that is the total answer that we're looking for. The R is what we're measuring, and reactance is what we're measuring. So for peripheral airway, an example of peripheral would be asthma. So the resistance will be high, and it is frequency dependent. So with R5 being a low frequency for low airways, it will be frequency dependent for the resistance to be higher in the low airway than it would be the high airway, and the reactance will be low. So your airways are more reactant with asthma, and that would be how it would be interpreted on that test. For central airway disease, your resistance would be high and the frequency is independent. In other words, it doesn't matter if I give a frequency of 5 of sound waves or a frequency of 20. For the example of tracheomalacia for the central airway, it's independent. The tracheomalacia is not going to be highly resistant either way because it's the large airway. The restrictive airway disease, the resistance is not going to show a change, but the reactance is going to be low because of its fibrosis. So these are some examples, and I apologize for the blurriness, but most importantly, I wanted the graphs to be seen. The top left, so for each one of these graphs, the upper level normal is the black line, and the lower level normal is the black dotted line. So the colors in the middle is where we want all of our tests to be reading at. The orange is the resistance. Sorry. And the blue-purple is the reactance. So the top left is normal because everything is reading right in between the upper level normal and the lower level normal. The bottom left for the central obstruction, the resistance, you see, he kind of took over at the top. The resistance is too high. So the upper level of normal is no longer top dog. The resistance took over at the top. So he's got a high resistance, but the reactance on the bottom is still within normal range. For the peripheral disease, the top right, the upper level normal is still normal, and the resistance is still within normal range. But if you look at the bottom, the purple line, the reactance is below the level of normal. And the severe obstruction, everything's abnormal. So when you look at the solid black line and the dotted black line, there's nothing within normal range on that one. And that means everything's out of whack. These are some examples from our actual clinic. These are not children. These are volunteers. And the first one's me. Ta-da! Very normal. I do not have CF. I do not have anything. I am normal. So the upper level normal line, my resistance is normal. The blue line for reactance, that is also normal. The middle graph, another normal example, but slightly different from the first. The third one I thought was interesting. It is still considered normal, but if you see, the frequency is at the bottom, 5 to 20, 5 to 19 technically because of our system. But it started off being normal, where the reactance was slightly above the black dotted line, the lower level normal, and then it slightly disagreed, but it ended up still being normal. It just goes to show you that everything is not going to be cookie cutter. It is not going to be exact. It is not going to be textbook. And just because it looks slightly off or because the graph is not on the exact line, it doesn't mean it's abnormal. So this one will still read as a normal test. So when should we use this? For our clinic, these are some generals. For ages greater than 2, we look for, do we have recent images that show increased concern for them at a younger age? Do they have increased need for antibiotics? Do they have a new bronchiectasis diagnosis? And are they unable to successfully complete spirometry? I'm aware that a lot of clinics can do spirometry at a younger age, but I'm also aware that every kid is 100% different than other people. So there are some that are 6 years old. We've had some ourselves that you would think they could get in there and do spirometry, and they have good days, they have bad, and sometimes every day they see you is bad. And that is okay. And that's an FOT baby. If you really need them, they have bronchiectasis, and you can't get spirometry, then there's no reason not to try this if you have the equipment. It's better than not getting anything at all. So those are some good guidelines to follow if you need to get something and you have this available. Some basic spirometry statistics. We can look at the successful, but the bright red numbers of unsuccessful for preschool age children. For 3 years old, 40% of unsuccessful spirometry, 25% of 4-year-olds are unsuccessful, and 15% of 5-year-olds are unsuccessful. I know a lot of pulmonologists think that 5-year-olds should be able to do it. Well, right here it says 15% are still unsuccessful. So if you need to get spirometry, you need to get some test results, and you have a 5-year-old and they can't do it, and you have all these other test results proving that you need more answers. If you have FOT available, then give it a try. It's just tidal volume breathing. I tell them there's no owies involved, and normally they're willing. It's difficult to objectively assess pulmonary function in the preschool age children. FOT allow rapid collection of large amount of data in a matter of seconds on a spontaneously breathing child breathing at normal breathing frequencies, and relying solely on spirometry to monitor the progression of CF lung disease and evaluate treatment effectiveness is insufficient when we have other options. So some basic techniques. They kind of look like this cutie here. Hands on their cheeks. When they're little, I don't trust them to put their own hands on their cheeks because I just don't trust them. They do a regular antibacterial filter, nose clips, just like regular spirometry, mouth seal, hands on cheeks, 10 to 15 calm tidal breaths. I do not tell them how many. They all think that they can count. Some can, some cannot. I tell them it feels like a slight vibration. If they're a CF kid, most of them at this age have had a vest, know about a vest. If they're from Canada, they might not know what a vest feels like. And I tell them it feels like a little drummer boy inside your chest because that's just what it feels like. And ideally, we do about 3 to 4 tests. Per ERS standards, it says 3 times. Couldn't find ATS standards, but 3 is the goal. So who could we test? Pretty much anyone who can sit upright. It's non-invasive, it's versatile, demands minimal cooperation. You still have to talk with them, give them some basic instructions. They're little. If they're in the age group we're looking at, they're less than 5. You have to sit in the chair. You cannot sing to me. You cannot hum to me. You cannot talk to me. Do not stick your tongue in the hole. There are still basic instructions that they have to have. Had one the other day who was upset that her YouTube video stopped, so she decided to pull her mouth off the test and said, but it stopped. I'm like, well, so did you. Now we have to start over. So there's still basic instructions we have to give, and we have to remember there are children, and there are a reason they are children, and there's a reason we chose to work with children. So we have to meet them where they are. Comparative review, forced oscillation. For FOT is measured at tidal volume. Spirometry is measured at a forceful inhalation and exhalation. The FOT measures the R, the X, and the Z. Spirometry measures the FEV1, FVC, the ratio, and the 25-75. FOT is effort independent because they literally just have to sit there and don't sing to you. Spirometry is effort dependent. They literally have to follow instructions. The FOT has increased small airway sensitivity, and the spirometry is less sensitive for the small airways. And the FOT has minimal contraindications, and spirometry has contraindications, but it's mostly for less than 5 or the elderly. One thing I'm supposed to tell you is spirometry is still gold standard. That hasn't changed. So in conclusion, objective measurement of lung functions are still critical for treatment and study of lung diseases such as CF. Spirometry is the most widely used and accepted method of pulmonary function testing in CF, but not all patients can perform the maneuvers. And using innovative, increasingly available PFTs, such as multiple breath washout, FOT, IOS, combined with their correlation to conventional tests, spirometry and plethysmography can help detect lung disease much earlier. And that's it.
Any questions?
Oh, doesn't work, you don't get to ask, sorry.
From Little Rock, Arkansas. Okay, I guess
Oh,
that now it's working. So, thank you for a nice presentation. I had a comment and a question. So the first comment is that current reimbursement guidelines do not allow you to bill the same day spirometry and impulse oscillometry. So that's the first thing. The second thing is that if you do, you're going to do both, you have to do impulse oscillometry first, because if you do spirometry first, that alters your oscillometry. What creates a situation where you're trying to get to the gold standard of getting spirometry, and you try to start earlier with these children, but also you're being subject to your productivity. That's the day that we live today. So that I was curious about how you manage that and how you decide and what support you have for this. Probably lots of times that you will not be reimbursed. And just a brief other comment that there are other portable devices besides the one that you use. At least there are 2 commercially available devices out there.
We do have support in our clinic as far as deciding which one to do. Sometimes we decide before they get there based on the kid. And sometimes we wait and see how the kid's behavior is when we get there. If I know that I've done FOT with the patient before and he did fine or she did fine, we're just going to go ahead and do it because we need repetition and we need to know how they're doing. If I've been working with spirometry with the same patient and last time we did both, obviously you cannot bill for both on the same day, but you can do teaching with spirometry, but use the report for FOT for consistency. If I think for spirometry, we can go ahead and do that. The goal is to get them from FOT into spirometry so we can use spirometry as the gold standard. But when I can't have spirometry for results, then FOT is the go-to. I hope that answers it.
Thank you very much.
There's one over there.
Quick question.
Yes, one more. We have time for one, yeah.
Is this on? Oh, there it is. Hello. My name's Kate Metcalf. I'm from Eastern Maine Medical Center up in Bangor, Maine. The FOT machine itself, does that require a gas source for the testing? I'm just thinking as far as like being able to take it from my PFT lab over to our CF clinic. So
It does not require a gas. It is portable.
it is portable. Thank
It
you.
is quite top heavy. Just warning you.
Fair enough. Thank you.
Yeah.
Is it on a stand, like on wheels, so they can just wheel it over?
It can be. Mine is not. Mine is attached to a table like this, but we've looked into putting it on a stand, but because it's top heavy, IT seems to think that's a problem.
Fair enough.
Can I make a comment about that? Yeah, hi. Clement Wren, you actually cited one of my papers. Yeah, well, it depends on the device, right? Because so there's 3 clinically available FO devices, right? The iOS, Resmon, and the TremorFlow. The TremorFlow is very portable. In fact, you can go out and people are actually using it to do oscillometry in the field for research. So that device is very easily portable. It just comes that and it's connected to a laptop. But it's true, like some of the Resmon and the iOS would be harder.
Yeah, the Tramfo is the one that's like the size of like an iPad, right?
Yeah.
Yeah.
So there is the feasibility, if you're going to have an inpatient to outpatient center, that there's different devices that can support you.
Yes, basically.
Got another question here from the app. How long does it take a child to perform this versus spirometry, and is it expensive?
Price, I think, is equivalent. I don't do much with the billing numbers. Oh, sorry. Price, I think, is equivalent. I don't do much with the billing side. I just type in the codes and hit go, but I haven't heard any difference with it. Time-wise, they seem to be close to the same, except for when you have someone who cannot do spirometry, it takes a lot of coaching and a lot of time. And as we know in clinic, time is money. So I think FOT can be faster when it's a patient who is not capable of doing spirometry.
Okay, thank you so much.
Okay, thanks.
Okay, next is my main man, Kenny.
All right, yeah. My name is Kenny Harker. I'm the supervisor of respiratory care at Corewell Health in Grand Rapids, Michigan. And we're going to talk about some PFT interpretation using the lower limits of normal and Z-scores. So using the lower limits of normal is not new. The 2005 ATS-ERS Interpretive Strategies for Lung Function Tests technical standard recommended this practice to identify abnormal versus abnormal. In the most recent update of this technical standard in 2022, they made it a requirement. However, if we polled the audience right now, I think we'd still see that percent predicted and fixed cutoffs are still being used to interpret PFT testing. And change is hard. Using this method assumes that the lower limit of normal is 80% of predicted, and anything less than 80% predicted would indicate abnormal results. So before we talk about the lower limit of normal and using Z-scores, we first might want to look at why we might not want to use percent predicted as the lower limit of normal. The use of percent predicted as the lower limit of normal is statistically flawed and more statistically sound, and a more statistically sound method would be an expectation of a 5% error as indicated by the solid black line. And we can see in these graphs that the major limitation to using less than 80% of predicted to represent abnormal results and to grade severity is that it does not take into account the age-related changes in measurement variability. Using the method of identifying abnormal results with the values less than 80% will lead to a higher increase in false positive results in the elderly. And similarly, using the fixed cutoff of 70% for the FEV1 over FEC ratio to establish airflow obstruction will result in underdiagnosis in the young and overdiagnosis in the elderly. To use the percent predicted as the lower limit, sorry, my apologies. According to Kwanhir et al., it has been ingrained in respiratory medicine to express measured values as a percent of predicted. It's a tradition that probably arose from the recommendation by Bates and Christie that said, a useful general rule is that a deviation of 20% from the predicted normal value is probably significant. This rule is only true when the scatter around the predicted is proportional to the median value, and that's not always the case with PFT values. In this graph, we see at a very early ages, and then again somewhere between around 45 to 50, that the spirometry values will be falsely misclassified as abnormal when using the 80% of predicted as the lower limit of normal. And then just another way to view the limitations of using the less than 80% of predicted as the lower limits can be seen here in this chart, where using less than 80%, in this chart here you see that the lower limit of normal is the 5th percentile, and what that would correspond to as percent predicted. while it works okay for FEV1 at younger ages, it does tail off as we age. And certain values that we measure, like DLCO, total lung capacity, and residual volume, may not always be at 80% when we look at the lower limits of normal in the 5th percentile. So what is a Z-score? I didn't sign up to be a statistician when I became a respiratory therapist, but but it's okay. Z-scores are rather simple and easy to understand and to put into practice. A Z-score, or a standard deviation, represents how far an observed value is from the median. In the normal distribution of data, we can expect that 68% of healthy population will fall within 1 standard deviation of the mean, and 95% to fall within 2 standard deviations. And most spirometry values are characteristically too low in disease rather than too high. So we can expect that the lower limit of normal to be set at the 5th percentile, equaling a Z-score of minus 1.645. And this will result in a 5% error, false positive error. When the reference equation data is distributed evenly in the bell curve, the predicted or median value is put in the middle, and this is often referred to as 100% of predicted, but also known as the 50th percentile. So the ERS and ATRS, technical standard interpretive strategies for lung function, have set the standard at using the 5th and 95th percentile to identify abnormal PFT results. The rationale for Z-scores is that it represents how far an observed PFT value is from predicted value, and accounting for sex, age, height, and what's in question at this point now is ethnicity, and we'll hear more about that in the next talk. It also allows for a more consistent way of assessing impairment across the age continuum. When grading lung impairment and lung severity, the ATS-ERS has recommended a 3-tier system, where anything less than 1.645 to a negative 2.5 would be considered mild impairment. Negative 2.51 to 4 is moderate, and anything more than a negative 4 would be severe. In this graph here, we see how that 3-tiered system compares to what we're all used to of using percent predicted to look at lung impairment. And this works well until we reach the elderly ages. And here's an example of where even the limitations of the 3 Z-score system may not work as well either, as we see a lot of elderly patients who were historically classified as severe or very severe in getting pushed into a more moderate. So let's put it into practice. And just looking at PFT values here, for this patient, this would actually be classified as a normal PFT. When you evaluate the ratio first, it is above the lower limit of normal and has a Z-score of 0, while the FEV1 and FVC scores are also above that lower limit of normal. In this one, we have a normal FEV1 to FVC ratio, so there is no airflow obstruction. But when we look at the FVC and FEV1, they are both below that lower limits of normal. So we are looking at restriction and would want to follow up with lung volumes to confirm that restriction. Again, in this example, we have a ratio that is now below that lower limit of normal and an FEV1 that is in the mild impairment range with a Z-score of minus 2.1. This patient would be classified as moderate impairment with airflow obstruction. And then when we look at our lung volumes, in this particular case, we're looking at mild restriction with a Z-score of minus 2.46 and air trapping is also suggested with the increased RV to TLC ratio. Looking at the DLCO, results for this particular example is severely impaired due to the result of 4.1 mils per minute per milliliters per mercury being below the lower limit of normal, and a z-score that is minus 6.98. In conclusion, we'd want to move away from using percent predicted as an indicator of lung health and grading lung severity, as it is age biased and not statistically sound. Moving to the method of lower limits of normal and z-scores presents a more statistically sound method, and we should trend actual data versus the percent predicted and treat the patient, not the numbers. Here are my references. And any questions? Yes.
Hi, Tassos Kouboulis from Washington, D.C. That was a nice presentation. However, it is a little irrelevant to pediatrics, for example, because all of these things are based on adult data. Spirometry is based on volume, and the volume in children changes normally. So whatever in adult population, it makes sense to use a lot of these assessments because we assume that the lung volume is supposed to stay the same. All of this data, for example, if you have an FEV1 over FVC in a child that is 60%, it's time to call for a transplant. It's a very, very, very severe obstruction, as opposed to an adult that can be just the aging process. And the issue of the z-scores, it's just one statistic versus another statistic. Okay, let's not kid ourselves that it is something revolutionary and it tells the truth. It's just another statistic to present data. So personally, I'm not really sure, that it provides anything better than the percent predicted. Not to mention the fact that 99.9% of the population understand the concept of you are 50% of the normal as opposed to you are a z-score of 2.75, which means nothing. So that's not against your presentation, it's against the z-scores.
No. Thank you. Thank you.
Thank you, Kenny. Okay, next we're honored to have Dr. Margaret Rosenfeld. Dr. Rosenfeld is a professor of pediatrics at the University of Washington and Seattle Children's. She is presenting to us today on global race-neutral reference equations. Welcome, Dr. Rosenfeld.
Well, I'd like to thank the moderators for inviting me to speak today, and also to you, Mr. Harkin, for so graciously setting me up in terms of explaining z-scores. And we can have an offline conversation about the importance of z-scores, because I happen to think they're very important. So I'm going to switch gears slightly and talk about Global Lung Initiative, which I'll refer to as GLI, Global Race Neutral, or 2022 reference equations. Here are my disclosures. So an outline of my talk. First, I'll talk about why we should be switching to GLI Global, or GLI 2022, the impact of this switch on the interpretation of lung function in people with CF, and then how do we explain the effect of the switch to our patients. So I think, as most of you in the room are aware, until recently, professional societies such as the American Thoracic Society have recommended the use of race-specific reference equations. And in particular, ATS recommended until recently the use of GLI 2012, which is race-specific. And just to remind you of what GLI 2012 is, it was actually an incredibly enormous undertaking to take healthy reference data from all around the world and agglomerate it into one set of reference equation that covers people ages 3 to 95 years. So the data come from healthy individuals around the world, though disproportionately in higher income countries that do spirometry on a regular basis, ages 3 to 95. The cohort is overwhelmingly what they call Caucasian, about 57,000 Caucasians. And just so you know, because in CF, the most prevalent minoritized population is Hispanic or Latinx, and they are, in GLI 2012, characterized as Caucasian. And so that's important when you think about the switch to 2022. African Americans were a small group of about 3,500, North Asian and Southeast Asian slightly larger. And then the other group is an unweighted average of these four categories. And you can see on the right-hand panel then the predicteds and how they vary by racial category. However, there's a lot of increased emphasis on making sure that our either normal values or reference equations serve health equity in this country. And so a lot of different uses of race-specific equations or norms are really being reevaluated in everything from kidney function to lung function. And in 2023, the ATS recommended switching from the race-specific 2012 equations to the race-neutral 2022 GLI reference equations. I was lucky enough to be on this very thoughtful and committee with lots of vigorous discussion, I would have to say. It was challenging to come up with this recommendation. But the relevant part is that we recommended replacing race and ethnicity-specific equations with race-neutral average reference equations, which must be accompanied with a broader reevaluation of how spirometry is used to make clinical, employment, and insurance decisions. And I think that second half of the phrase is really important. You'll see there just is less certainty now about what is normal versus abnormal, Z-scores aside, when we think about the effect of race and ethnicity on the interpretation of lung function. So why should we be making this switch? Well, first of all, race is a social construct. And really, poor health outcomes among minoritized populations are due in large part to exposure to implicit and overt racism, as well as adverse social determinants of health and environmental exposures. So now that we understand that, the use of race and ethnicity in lung function interpretation really contributes to a false view that the differences in lung function are due to fixed biologic differences rather than the effects of structural racism and societal structures impacting health outcomes. So by setting a different benchmark or normal for each race, race-specific reference equations really normalize the differences in pulmonary function that are actually due to adverse social determinants of health and environmental exposures, and therefore help to perpetuate health disparities. So for those of you like me who are visual, you can see that there are just so many factors that influence lung and airway growth. So there's socioeconomic status, which feeds into environmental exposures and adverse social determinants of health. There's structural racism. There's definitely ancestry, and we had a big discussion about using ancestry as determined by genetics to inform lung function reference equations, but that is not a clinically useful observation at this point in time. Whoops. There's adverse nutrition. There is definitely standing height, but that doesn't explain very much of the difference between races. There's epigenetics, there's health behaviors, and all these different things feed into lung and airway growth. So let me remind everyone where the GLI 2022 equations came from. So it uses the same underlying data set as GLI 2012, the one I presented to you a couple of slides ago. But the race-neutral curves are the weighted average of those different racial groups that I outlined. So since it was predominantly Caucasian, it upweights the contribution of the other groups and downweights the contribution of data from the white population. And so you can see that in the reference population down below, the lung function, so now that there's a single bar for all races and ethnicities, the lung function of people who report themselves as white looks a little bit better, and similarly for Hispanics, but people who are reported race as Black definitely look worse. Their lung function looks worse with the race-neutral reference equations, since the bar for them is now higher. And it's also important to note on this that the GLI other is a very good substitute for 2022 if that's not available in your lab, if you categorize everyone as having the other race or ethnicity. So now let's zoom in on the CF population, where the impact of the change from 2012 to 2022, or race specific to race neutral, will be different since the CF population has a different age, height, and FEV1 distribution compared to the reference population. So we published this paper last year looking at the impact of switching to race-neutral reference equations on FEV1% predicted in people with cystic fibrosis in the National Patient Registry. And here you can see our probably most important results. So the panels are white, black, Native American, and then Asian, Hawaiian, and Pacific Islander, and then those who categorize themselves as other in the registry. And then you have the percent predicted FEV1 along the x-axis. And the take-home message is, first of all, zoom in on the white, and you can see that in switching from race-specific 2012 to race-neutral 2022, the lung function appears better. Everyone's above that 0 line. And if you look at the black, everyone looks worse. They're all below the 0 line. And that's fairly true also for Native Americans. And for Asians, it's a little bit more like the white. And then the other groups are really hard to make any sense of in terms of generalizability. The second thing to notice here, though, is that the higher your baseline lung function is, the bigger difference you have in switching from GLI 2012 to GLI 22. And so you can see that the gap between 0, which is no difference, and the observed difference is much higher the higher your baseline lung function is. So this switch is going to impact younger kids and kids with higher lung function much more than older patients and those with more severely impaired lung function. So how will the switch affect reported lung function in my CF patients? So first of all, percent predicted FEV1 or Z-score will generally be higher for white and Hispanic patients than with the old equations, and lower for Black patients. And on average, it's also important to note that the change affects Black individuals more than it affects white individuals. So the mean change in percent predicted FEV1 with the switch is about 8% decline in Black individuals, where it's about less than 5% improvement in white individuals. And also, I didn't show you these data, we put them in the paper, but the changes are also greater for those in patients under 20 years of age. And of course, as I just said, those with higher initial lung function. So I'm gonna sprinkle a couple of examples in here, which I think are very illustrative. So the first one is from a 60-year-old man whose mother is white and whose father is Black, which brings up the question of how do you categorize him if you're using GLI 2012. So if we categorize him in GLI 2012 as Black, you can see his FEV1 is 62% predicted. If we categorize him as white, it's 53% predicted. And then if we move to race neutral, it's 55% predicted. So this is meant to be confusing. You can see why race is so challenging to work with. So depending on which GLI 2012 racial category we use, his FEV1 percent predicted when we switch to GLI 22 is either 2% higher or 7% lower. Now, let's move on to thinking about how this affects clinical care and clinical trial enrollment as well. So lung function, as we're all keenly aware, is deeply embedded in the monitoring and care of people with CF. Percent predicted FEV1 is a predictor of survival and quality of life. It also guides referral for lung transplantation. And it's used as an eligibility criteria for clinical trials. But I'll say this now, and I need to say it again. The reference equations for clinical trial participation are not standardized. And as far as I know, there's no attempt to standardize that as of yet. And acute drops in lung function obviously guide diagnosis and management of a pulmonary exacerbation as well. So changing the reference equations can really have profound impacts on interpretation and use in clinical care. So let's look at lung transplantation candidacy. We all know that lung transplantation referral is guided by exacerbations, clinical symptoms, life impairment, but also by FEV. And so in adults, we consider referring for lung transplantation at 50% predicted or less, but definitely at 30% predicted. And for kids, it's a little bit higher. But those numbers, particularly FEV1 30% predicted, are really deeply embedded in our minds. So you can see that that's really going to affect referral for transplantation if somebody's numbers switch out or into one of these categories based on using GLI 2022. I do also need to point out that the choice of equations doesn't actually impact the allocation of lungs because it's not part of the composite allocation score, but it definitely impacts consideration for referral for transplantation in the CF community. Next, let's look at clinical trial eligibility. This which will definitely affect clinical trial eligibility. So a common FEV1 group for clinical trial eligibility is those whose FEV1 is between 40 and 90% predicted. So here again from our original paper is looking at people who would be recategorized as an FEV1 less than 40% or greater than 90% using the new equations. So if you look at the white group who are an FEV1 less than 40%, it's about 5 or 6%, doesn't change very much, switching from GLI 2012 to GLI 22. However, for blacks, for blacks it's a little bit different, but not a whole lot of change either. Because remember, at the lower end, there's not as big a change. The bigger change is up higher with the FEV1 greater than 90, and you can see that with the switch of reference equations from 2012 to 2022, there are more white people who have an FEV1 greater than 90%, goes from about 48% to 56%, and goes the other way among blacks, goes from 51.5 down to 37%. So really important differences. So let's move to example 2 of a 24-year-old who's wondering about inclusion in a clinical trial. Her father is black and her mother is from Japan, and she identifies as mixed race. So if we categorize her as black, her FEV1 is 41% predicted. If we categorize her as Northeast Asian, her FEV1 is at 36% predicted. And if we move to GLI 2022, it's at 37% predicted. So you can see that that kind of arbitrary cutoff of 40% predicted for inclusion in a trial would allow her to go in if she was if we use GLI 2012 black, but not the other two. So, as I said, I would repeat that clinical trials haven't uniformly switched to GLI 2022. So if you're a research coordinator, you need to be looking at what reference equations are recommended, if any. So you can see now that the switch to GLI Global really can have important consequences for clinical care. By using race-specific reference equations, we may have potentially underestimated the severity of lung disease in people with CF who are reported as black and potentially delayed lung transplant discussions. That's a pretty sobering message. In addition, minoritized people with CF have always been underrepresented in clinical trials, and the use of race-specific equations likely prevented participation of some black people with CF with higher lung function from joining clinical trials. And in those with low lung function, it's maybe allowed more of them to participate in clinical trials, but potentially at the cost of delays in lung transplant referral and disability qualification. So some major shifts that we're thinking about here. Whoops, sorry. So although the switch to GLI Global addresses an important health disparity for black people with CF, you can see, because you're probably confused too, how it could lead to confusion and concern for our patients and families. So that's what I'm going to spend the rest of the, not too long, don't worry, talk discussing. So let's turn now to how we explain the changes that we see to our patients. I think the first thing is having a really thoughtful discussion of the rationale for switching to race-neutral equations. And you could say something like this: we now realize that reporting lung function with race-specific prediction equations may have normalized the lower lung function among black individuals, of course of the same height and age, due to systemic racism, contributing to underestimating disease severity. And we need to emphasize to our patients that their actual lung function hasn't changed all of a sudden. They haven't all of a sudden gotten sicker. It's around the interpretation of their lung function by changing these reference equations. So now, since so many of you are in the clinical PFT lab, how can clinical labs help smooth this change? The first thing is to consider calculating percent predicted values for all measurements over a year using both reference equations, so you can kind of see how they march along, and that overlap, I think, will help to ease things. And a table of these comparisons could be used to enhance discussions with patients and families, or a report that has both. For adults, you could consider using the absolute FEV1 in liters. I don't know how understandable that would be to patients, but it's not helpful at all in kids. I'm a pediatric pulmonologist because, of course, they're growing. I really want to give a huge shout out to the CFF GLI task force and some members of it, including myself, but very important ones in the audience, really helped with these materials. And there's a link here that you can find on cff.org. They're really, really helpful handouts for our patients and indeed also for the care teams. What are you going to do if your lab has not yet switched to GLI-22 or has decided not to switch? Obviously, PFT labs are PFT labs for all our patients, not just those with CF. So it's a complex decision that affects all of our patients, and there may be many reasons why a lab either hasn't switched or has decided not to switch. So if your lab uses GLI 2012, you can choose the race for every single CF patient as other, and that yields results that are very similar to GLI 2022. I do need to point out that your SMART reports have already switched to GLI 22, so you're going to get confusion if your PFT report from the lab looks really different. There's also the free online GLI 2022 calculator from ERS, but the problem is you have to plug in each individual patient's results and it'll spit out the GLI 2022 Z-scores and percent predicted. So in conclusion, switching to race-neutral reference equations is one small step towards health equity, and we no longer accept a lower bar for lung function among Black people. But so this makes us realize that we may have been underestimating disease severity in Black people with CF, particularly at the high end of the lung function range. We have to be clear that an apparent sudden change in lung function with the switch could cause confusion and distress, and we have to have really careful discussions with our patients and families about the rationale for this change and reinforce that the individual's lung function didn't itself suddenly change. We also need to discuss, and this is hard to do, I think, the inherent uncertainty in reference equations and to evaluate lung function within the larger clinical context. So there's clearly more work to be done. I'd like to acknowledge the CFF Registry Committee, Elizabeth Cromwell, who leads that, and then the CFF Global GLI Task Force. Thank you.
A couple questions here from the app. If using GLI 2022 race neutral, should we still use other?
So there is no other because there's no race anymore. So you don't have to make that choice.
Can you please clarify if the race neutral equations only affect FVC and FEV1 values? Should we enter other for all patients who have more accurate readings for the other reported values, such as FEF 2575?
Yeah, so GLI 2022 doesn't have reference values for FEF 2575. It only has FEV1, FVC, and the ratio. And so you'll get accurate readings for all of those.
Hello, I'm Kristen Holmes, respiratory therapist at Mayo Clinic, Florida. So 2 questions. First question, so we have the race equation, race neutral equation for spirometry, but sometimes that can give us a very different results, right? So that means that in spirometry, they could be either low or normal. And then when we go over to pleth, it could read something completely different. Is there a equation that's going to eventually come out for pleth that can make them congruent and not give possibly different results?
Yeah, that's a really great question. So the answer is no, because almost all of the data on actually pleth and DLCO that there's GLI reference equations for are from Caucasians. And so there's no, so basically they're not representative of enough of other races and ethnicities to draw any conclusions.
Okay. And the second question I always get, because I do have adults, so when I have this big change, we kind of go on whole numbers, like you said, the actual liter flow. And this, I mean, you may not know the answer, but the question that I always get is, why did this take so long? So as far as a race-neutral equation, what made it 40, 50 years later? Kind of like, why now is this the question?
Yeah, that is a really great question. I think there's just, I would be too humble to really be able to give you a good answer, but I think there's just been a growing understanding of the fact that race is a social construct, and that really it's social determinants of health that may be driving all these differences. So we really need to acknowledge that and hopefully be able to improve the lives of minoritized people so that these differences are reduced.
Along those lines, do you expect to see maybe more changes in the near future as we understand more and more social determinants of health across various diseases such as COPD and as those are implemented in different health systems across the country and world?
Yeah, that's a great question too. You know, there's a whole flurry of papers that are coming out now looking at the effect of the switch in different whole bunches of different lung conditions. And I think we're going to learn a lot over the next few years as we start to drill down on why and what to do about it.
Yes, I would like to make a quick comment that whatever predictors you use may make a difference only in the first measurement. When you measure a person for the second time, you measure them with themselves, and the predicted values mean absolutely nothing. If my FVC and my FEV1 drop by 20% absolute value compared to 6 months ago, I'm having a serious problem. And I don't need a predicted value to say. So we need to clarify this thing, and this is one of the concerns that I have with the terminology that is being used, that when we decide for somebody with a transplant, it's not that we pick up people, we measure them one time, we compare them with whatever standard we have, and we say, okay, you get it and you don't. You are going to follow them for a period of time, and they are going to show you that they are decreasing, and you say, okay, now you are sick enough that I need to refer you. So let's clarify these issues, that a lot of this discussion is like we try to find solutions for a problem that does not exist, actually. The patients are being measured, you see them routinely, and you see whether they're getting better or worse.
Thank you. This time I actually agree with you. So I think that's just such an important point to make. It's like a recalibration, but then things will move forward without any recalibration. So it's kind of like the intercept changes. We don't know for sure, actually. That's one of the additional analyses that we're going to do. We don't think the slope changes much, but I think the recalibration is really important. You know, in 5 years, when everything's kind of just going along, it'll all fade away, and this happened when we changed reference equations in the past. But right now, with this sudden shift, it's kind of in everyone's face.
I also agree with you. I'm Kristen from Arkansas Children's. I'm the respiratory care supervisor there, and we have recently switched to GLI Global. And we do get a lot of, oh my gosh, that's a big change. So I wanted to just let everybody know, if you guys are using the new predicteds and you're getting that from your patients, your PFT software is highly customizable. So if you would like to work directly with whoever your software company is, they can make a report that just looks at actual values. And so you could trend that just to have something to show your patients. You are actually getting better regardless of if your percent predicted dropped. So just having a graph like that. You could customize your own reports.
Thank you so much. That was wonderful.
Yeah.
All right, next up we have Renee Jensen, and she has been a registered respiratory therapist at the Hospital for Sick Children in Toronto, Canada since 2003. A long-standing and keen interest in pulmonary physiology, Biomedical Technology in Pediatric Lung Disease paved the way for transitioning from bedside care to CF clinical research in 2008. In her current role, she's provided oversight for sick kids CF clinical research, multiple breath washout lab, and her research focuses over the last 16 years has been related to the implementation and support of multiple breath washout in CF clinical research, and the potential utility of this methodology in the clinical care of children with CF.
Thanks very much for having me here today. I'll try not to stand between you and your dinner too long. So just to kind of chat a bit about multiple breath washout and LCI today, specifically in the context of sort of modern CF care, CF research. These are the disclosures I have related to this presentation. So as everybody here, I'm pretty sure I see lots of familiar faces. So some of this information is probably going to be familiar to some people, but I'm sure the talking about spirometry is familiar to everyone. So I guess the question that we often get right off the bat is, why do we need a new, another pulmonary function test? And I think listening to some of the earlier presentations today about novel techniques or FOT, for instance, that there is some opportunity for, although spirometry is still the gold standard, there is some opportunity for alternative tests to add complementary information. So just a little bit about how MBW fits into that picture in terms of spirometry. So as everybody knows, it is the most common lung function test performed in the CF population. It is an effort-dependent technique. And to kind of harken back to the good old days of the physiology class, FEV1 is primarily influenced by airways resistance in the large airways, but it is relatively insensitive to obstruction in peripheral airways, which is the primary site of gas mixing, although it is the sort of highest surface area, biggest volume, the gas mixing, and is the primary site of gas mixing. FEV1 is relatively insensitive to changes down there. Specifically in context of early CF lung disease, so when we have inflammation and structural abnormalities that occur in the peripheral airways, that typically happens in a heterogeneous pattern. So there's areas that are more or less affected than others, and that sort of uneven pathology can mask, that can allow for masking of healthy areas to mask more diseased areas. So lots of children with CF do actually have evidence of structural abnormalities despite having an FEV1. And as everybody is aware who's done it, spirometry requires cooperation technique and is often difficult for the younger ones. So just a bit of a snapshot of the median FEV1% predicted in Canada. This is figures from the 2023 Canadian CF Registry report, and whether we should be reporting the FEV1 or the Z-score now. I don't know if it's flawed now, but nevertheless. Median FEV1% predicted in Canada, you can see is presented on the y-axis over years, age in years on the x-axis. It's a 5-year moving window looking at the median FEV1 from 2003 to 2022, so roughly about 20 years. The blue line showing the median FEV1 across the age range in 2003 versus the orange line showing the median FEV1 across the age in 2022. And what should be pretty apparent from this figure is that overall lung function is improving. So the 20-year, the gap between those 20 years just in general is pretty significant. And in a relatively large proportion of patients, sort of from that early mid 20s to childhood down to childhood, are sitting in sort of that over 80% predicted range, which may or may not accurately reflect normal, but nevertheless, they are sitting in there. So by 2022, a good proportion of kids in that early and young adults in that age range are sitting in quote unquote the normal range. And as you'll notice, there's missing data sort of sitting in the younger kids. Down around the 6-7-year-old range. So it is relatively unreliable in that age group. So for all those reasons, we do need alternative lung function tests. And that's where the multiple breath washout can potentially add some complementary information. So the multiple breath washout test, or MBW, is an effort-independent test that measures how efficiently an inert gas is cleared during tidal breathing. So essentially, it measures the decay of an inert gas, breath by breath as it's exhaled from the lungs. And it is a sensitive measure of detecting peripheral airway dysfunction. So it will capture disease in that group that was a little, or in that area, that range that was invisible to FEV1. So the figure at the bottom here shows a nitrogen washout curve. At the beginning of the curve, the gas concentration is steady, and then you can see the decay in the curve. It's shown over time, but each of those waveforms is a single breath. So what does MBW measure then? So essentially, it measures ventilation distribution. So as you're probably aware, healthy lungs are asymmetrical. Gases don't reach all parts of the lung equally, even in health. So layer onto that the patchy nature of disease that results in exacerbating that unevenness and resulting in more uneven ventilation distribution. And lungs that actually, and I guess on the right-hand side of the screen, you can see a figure of it's a hyperpolarized xenon MRI of an adolescent person with CF, and you can appreciate, just to illustrate the patchy nature of the disease, areas that are black are defects, so there's no ventilation reaching those airways. And areas that are white do have ventilation. So you can appreciate from those pictures that it's not very uniform. So since lungs are not ventilated evenly, that ventilation unevenness impairs gas mixing efficiency, which then is essentially what is reflected in the outcomes of MBW. So measuring ventilation inhomogeneity. So the multiple breath washout test then is able to quantify the amount of ventilation inhomogeneity by measuring how fast you can or how much you have to breathe in order to mix fresh air with existing air, gas in your lung, to clear that tracer gas from your lungs over the course of a number of breaths. So uneven gas mixing results in delayed clearance. And so that means that the more impaired the clearance is, or the more uneven the gas mixing is, the longer it will take to wash out of your lungs. So the primary outcomes of the multiple breath washout test or FRC, which everybody is familiar with. This is calculated by gas solution. So this is the FRC is calculated as the cumulative exhaled volume of tracer gas or whatever marker gas you're using to do the test. In this example, the inert gas is nitrogen. So the cumulative expired volume of nitrogen divided by the difference in concentration from the beginning to the end of the test, and that will give you the functional residual capacity. And then the lung clearance index actually uses the calculation of FRC in the calculation of LCI, and the LCI then is calculated by dividing the cumulative expired volume of all tidal breaths, so not just the tracer gas, not just the portion of the breath that's a tracer gas, but the entire sum of all exhaled tidal breaths. And then that is expressed relative to the volume remaining in the lungs, so the FRC. So the total volume that you exhale relative to your FRC then is the LCI. So it's a unitless number that excuse me, just represents how much you have to breathe to clear the gas relative to the size of your lungs, essentially. So thinking of in context of what weighs up, what weighs down, the lung clearance index is calculated to 1/40th of its starting concentration, meaning that the cumulative expired volume that it takes to get from start to 1/40th is an arbitrary endpoint, but that is the convention relative to the FRC. So that means that the higher a higher cumulative expired volume relative to your lung size means that the LCI will be higher, and it's taking longer for you to wash out the tracer gas. So in the figure here, you can it's just an example of LCI captured from a group of controls, so healthy controls versus a group of CF. It's old now, from 2005, but just to illustrate that relative to health, LCI is increased in disease. So in terms of the utility of LCI, this is kind of a busy slide, and it does highlight sort of our own research focus, not to say that it's not useful in other populations necessarily, but in terms of the utility of LCI in CF research that we've been involved in or that we're participating in, we do know that LCI can detect early pathological changes in CF lung disease. That's been kind of in the literature now for several years. It's sensitive to disease progression in preschool children, and preschool LCI goes on to predict lung function at school age. The preschool years, so you age 3 through sort of 5.9, just under 6, seems to be a crucial window for early intervention and provides an opportunity to intervene to preserve lung function potentially. The LCI is responsive to acute respiratory events, so measuring LCI during stable versus during a pulmonary exacerbation, it does increase at exacerbation and then can also capture recovery. It also is able to detect treatment effects and has been the primary outcome in a couple of clinical trials over the last few years. And it is able to correlate with lung damage that's shown on imaging, as you saw in the xenon MRI picture just a slide ago. And just a kind of a note that in the majority of those patients with the kind of abnormal imaging, many of those subjects have normal FEV1. And just to sort of put that sort of in today's landscape, knowing that modulators are going to be available to younger and younger populations, meaning that a higher proportion of the population will likely have mild disease. It can provide a window to treat or can identify, hopefully, a window to treat and preserve lung function. So in terms of MBW devices and options, there are several commercial devices that are available on the market. There's different approaches to measurement. So each of those devices has its own special way to to do the measurement, and kind of fundamental differences can occur in the variety of inert gases available. So you can either have a resident gas, so argon or nitrogen, as I showed in one of my previous examples, or the devices can use an exogenous gas, so a gas that is not present in the lungs and therefore has to be put there and then washed out. So a couple of examples of that would be SF6 or sulfur hexafluoride and helium. So in the figures at the bottom, just to sort of give you an idea of what the washout looks like for an inert gas that is a resident gas. So in the blue figure on the left is the nitrogen concentration by time. So that's just a washout curve. You can see that there's a period at the very beginning of plateau. That's a concentration stable at room air concentration, so around 78%. Then the subject is switched into 100% oxygen, and the gas, the nitrogen, is washed out as the person breathes 100% oxygen over a series of breaths. In the second figure, in the yellow trace on the right, you can see that that looks like a wash-in curve and a wash-out curve. And in this case, this would be an example of an inert gas that is exogenous. So in this case, it's SF6. And as I quickly mentioned before, you do have to wash it in before you can then wash it out. So the first portion of the figure is demonstrating the wash-in phase, where you have to breathe in, the subject has to breathe in the SF6 to a plateau, typically 4%. SF6, and then they are switched out then they breathe medical air, and the SF6 that was just washed in is then subsequently washed out, and the measurements are pulled from the washout curve. So just to note that there are definitely commercially available devices, but not everything is sort of created equally necessarily. And at present, gases and devices are not interchangeable. So just something to keep in mind as you're exploring options, if you are. So recognizing that equipment, technique, gases can impact MBW outcomes. An ATS working group was put together back in 2010 or something, around there, with a goal to provide some guidance to manufacturers to sort of standardize the equipment on some level. So the consensus statement for gas washout was published in 2013, I believe. And just an FYI, I believe that's going to be revisited and updated in the next year or so. So if you're interested, keep an eye out. Subsequent to that initial ERS ATS standard, there was a specific, there was a set of guidelines published specific to preschool testing, because they are a bit of a tricky group. So they got their own standards. And then for the research studies that we have been involved with, we have developed a standard operating procedure for the device that we've been using in research studies. So there are some standardization documents in place, but I would say that everything is not quite created equally yet. And so I think somebody mentioned earlier about all spirometers being equal. It's not quite the case yet with the MBW devices. So in terms of trying to be able to use MBW or LCI as an outcome measure in research studies, recognize that there needed to be some effort put into standardizing over and the test technique kind of and equipment sort of over and above what was written in these documents. And so we formed a central MBW overreading center network, or the CORC as we affectionately call it. It's a collaborative platform for MBW training, qualification site support, and quality control of research data or study data with the aim of collecting high quality research data with high feasibility. And we are the North American Center at SickKids in Toronto. There's a secondary center, or not secondary, I hope Claire's not here, another center in Europe at the Royal Brompton Hospital, and another center in Australia that was in Sydney and is now at the University of Queensland in Australia. And we work collaboratively together to help people use MBW in their studies. So part of what we provide to centers is MBW training and qualification. So standardized MBW training program was developed based on all of those standards that I mentioned just in the previous slide. We do provide training and qualification to MBW operators through a series of sort of a hybrid training program. It's partly online, partly in person, and then partly back at home again. So if you were interested in participating in the receiving MBW training, it would look like doing, I think, 3 online modules before you came to see us in Toronto for a day, where we would do some hands-on training, and then another session online as before you go or after you go home. Pass a little test. It's pretty easy. And then you would move on to collect some certification tests. And once which we do have some guidelines around in terms of the number of tests and the type of people or the type of subjects you need to collect the tests on. And once you meet the minimum requirements, which is an 80% pass rate, then you would be a certified operator, and we would issue a little qualification certificate. Just another quick note about the training and qualification process. For anybody here who's not from North America, it is standardized between the regional routing centers, so in Australia and in Europe, with some minor regional differences between the groups. To date, between the 3 of us, or the 3 centers, we've qualified about 350, just shy of 350 MBW operators. And in North America, we have qualified operators from 59 North American sites. So if you are interested, I put the little email up there if it is something that anybody is interested in reaching out about. We do have an email address that you could send a query to. Just to sort of end off, I guess the next step is a lot of people now are asking about, well, what's next and where do we go from here? And yes, it's good for research, and how do we get involved, and how do we do it, and how do we use it? And so I guess the question of transition to clinical care, there's definitely been growing interest to integrate LCI as a monitoring tool at CF centers. But as I said, things are not quite as established as they are with spirometry. And there's definitely some things to consider. Currently in our setup, if you've come to us for training or participated in a trial where we are the overriding center, you know that their data comes to us, we review it, and then you get a quality report sent back to you. Obviously, that wouldn't be feasible in a clinic. So there's a need for some real-time quality assessment tool or training. I think also some things that have come up actually in a recent planning grant or a planning study around looking at the implementation of LCI in clinic were questions like, or or requests for guidance around interpretation of LCI. So in a clinical setting, you get an LCI, what do you do with it? When is too high, too high? What do you do? How does it inform treatment decisions? How often should you be doing it? And it's, we often hear it's a long test, it takes a lot of training, et cetera. So how do you integrate that into clinics? So those are all definite potential barriers to integration into a clinic setting. But to address some of those, we do have an upcoming, hopefully, LCI implementation study. That, as I said, there has been interest from the CF community and also care providers who do think that it is useful to implement LCI in the clinical setting. And the goal of this light study then is to address some of those barriers to integration, specifically looking at point of care quality assessment and interpretation of LCI, feasibility of integration, and then utility of LCI to inform treatment decisions. As I said, it's all based on some fact finding from our pilot study or the planning study that was presented last year in a poster by Lucy Parham. And that's everything. So obviously acknowledging our team here. This is our Christmas photo. We were doing a singing contest. We sadly did not win. But it's definitely a team effort. And we do have a wonderful, great big team. So it's all down to them. So that's it. Happy to take any questions.
Questions?
Thank you for a very thorough presentation. My question is about the devices, and one of the challenges is that the Ecophysics device was not FDA approved until the last time I checked.
Yep.
So in order to incorporate that into clinical practice, it has to be FDA approved so you can bill for the time of the people doing the study.
Yeah.
So until there's that happening, it's sort of more of a wishful thinking that we can do that. There are other devices that are FDA approved that use other technology like rapid gas measurements that also do LCI. And probably there's need for comparison and validating that. If it's not FDA approved, it will remain a research tool.
Yeah, that's true.
So that's a major limitation.
Yes, and I'm always hopeful that there will be an FDA application put in soon. But you're correct. The device that this is built on, which was selected kind of just by, it was just fortuitous circumstances, I think, that at the time that some of the early studies that were being planned using LCI were in the works. The Xlyzer system was the system that happened to have a lot of the infrastructure that we needed in order to be able to use the test. So it doesn't mean that other systems can't be used. It certainly doesn't preclude anybody using a different device. But you're right, that particular device. Okay, Felix, thank you.
Hi, Felix Ratch in Toronto. So there's commitment of the company to move forward with FDA approval. The timelines are likely that this will happen, that the process will start and happen next year. So because they have done some changes to their equipment and they're currently doing it in Europe, but then they gave me the firm commitment that this is going to happen.
It's just hearsay from me. Cool.
Towards the end of your talk there, you talked a little bit about the interpretation being hazy, or how do you interpret this? How do you think that will correlate in the future with lung function at later ages?
Ooh, that's a good question, Felix.
Well, there's certainly some data that we can use. So there's the study that was done at Great Ormond Street in London showing that the preschool LCI predicts FE1 at school age, so that if you have an abnormal LCI, you're more likely to have an abnormal FE1 at school age. So there, these links have been built, but there is, in that study they used one time point measurement and 1 point later. And if we look at our longitudinal study, it certainly tracks over time, and so that is, and that goes along with some of the data from Europe, centers like Bern, who's done this for 20 plus years, and also support that. And they actually claim that based on their data, it's also a predictor of mortality, which has been established for FE1. So, so there.
It gets worse.
But you need for a measure that looks at early lung disease, that of course is challenging because you have this long lifespan of
Lots of
patients
things
which
can
you
happen.
So that becomes much more difficult in that sense.
Yeah.
Thank you. Thank you very much.
Yeah, you're welcome.
Thanks to all our wonderful speakers. Thank you to all our wonderful speakers today, and Kenny for putting this together, and we look forward to seeing everybody next year.